And this is the Zoom session for April 18th, 2017. We're going to go over some of the materials for tinnitus, and hope you get ready for the quiz. And we're going to go over any other questions you might have. Okay, let me just do one thing here. How's everybody been doing? You have any questions or problems that have come up, or?
No questions on my end.
Okay. Well, if you have some answers, I'd like them too. There we go. All right. Zoom. There we go. All right. Okay. So the first thing we're going to do, one of the things that, and I'm sure you've seen this on the other quizzes, basically I review some of the other materials that we've gone over from previous tests and previous sections, and I'm going to be doing the same type of thing. Are there medications that cause tinnitus? Anybody? I'd say anybody, but there's only two of you, so I'll say either of you. The mycins. Very good. Okay. If you would, do they just cause tinnitus, or are they ototoxic? Shell, do you have any idea? Most of them are ototoxic. That's correct. Now, in the myosin family, let's say you go to the doctor and he says, "Oh yeah, you've got a pretty bad sinus infection. I'm going to put you on streptomycin or erythromycin." Any problems? Would you argue with him about getting put on that? Oops, maybe we lost Rochelle. Dizziness is a possibility. Are all the mycins phototoxic, or just certain ones that you need to be aware of? Okay, streptomycin, doctors can give you that. Not considered to be ototoxic. Dihydrostreptomycin, you need to be careful of, especially if it's given in conjunction with penicillin or other antibiotics. So you just have to be careful. The streptomycins, this type of things, you have to be careful with all of them. And this is something that if you can limit your mycins, I probably would anyway. It's better safe. Okay, what family of antibiotics, not just what does it end with, but what is the family called? And most of you gotten that right in the last test. Michelle, any idea? Aminoglycosides.
Sorry, I don't have it in front of me. I'm trying to pull it up now.
Oh, it should be in the brain, right in the front. I know. One of the key things is knowing where to look it up. I think it was Einstein that said that. He says, the difference between a learned man and a smart man is that a learned man has things in his head. A smart man knows where to find everything else. I don't think he really said that, but that's the same as when Abraham Lincoln said, you can't believe everything you see on the internet. Is aspirin ototoxic?
I don't think so.
Okay, will it cause hearing loss, a permanent hearing loss, or other things?
I think it could possibly, there's something that could cause a threshold shift.
Okay, aspirin can cause some slight change in hearing, not usually. Most of the time, it will cause tinnitus. And if you go back when they were using aspirin as the primary medication to relieve the inflammation of arthritis and other inflammatory diseases, they would up the dose until your ears started ringing, then back off too. So they could get you up to 12, 15, 20 a day. And if it relieved the inflammation and your ears weren't ringing, they were fine with it. Of course, then you'd probably end up with an ulcer, but that's another whole thing. So aspirin actually wouldn't be in the ototoxic family, but it does have an effect on hearing. But it's the tinnitus. All right. And we have good old Roy Bain, who I know when he first started writing his books, we used to kid around and say he was the bane of our existence. But Roy Bain, when we were reading his article and we were going over his material, one of the things he was saying that does everybody have head noises or just some people? Did he make any statement one way or the other? Remember in the last session where I was stating that one of the things that I've explained to a lot of patients is it's sort of like this, system noise, engine noise. Everybody has it, but we don't notice it because when our hearing is within the normal range, we're perceiving our environment at a level higher than the internal sounds. So it's like looking out at a smooth bay. The rocks are underwater. When your hearing loss occurs, it's almost like the tide going out. The rocks didn't come up and stick out of the water went down. So this is one of the theories that Roy Bain had and was espousing early on. And I agree with him because I've talked to patients like this. What happens is if you, with normal hearing, go into an anechoic chamber, and these were studies that were done back in the 70s, back in the old psychedelic sensory deprivation study days. If you had somebody in an area where there was no sound, they started to hear all the noises that their body made. They would hear internal sounds. They would hear themselves breathing. They would start hearing their blood flowing through the vessels. And they would also hear odd sounds in the ear. So if we look at it from that standpoint, normal hearing brings in the outside sounds. So it brings those sounds above your perceived internal noise level, your noise sensation level. So it's all covered. If you get a hearing loss, those noises then become evident. They're more pronounced, not because they've gotten louder, but because everything else has gotten softer. This is one of the reasons that when you fit a person with amplification, a lot of times they'll say that the ringing has been reduced. There's been some amelioration of the noise in their head, because what's happening is they're hearing what's going on around them again. These may be the same people that say, I don't want to hear all that background noise. But that background noise is what covers up the internal noise. So if they were complaining of tinnitus before, this is what's really going on. What would your explanation be to someone who said, I don't want to hear all that noise?
That noise is what like
Noise is what?
that noise is what is part of your life. That is the natural surroundings around you.
Okay, well, why do I have to hear it?
Because we're not able to shut out certain sounds and turn up others.
That's right. If it's there, you should hear it. If it's not there, you shouldn't hear it. So if you're hearing something, it's like hearing a fan start, hearing a car coming toward you, hearing a bird flying at you. If it's there, you should hear it.
I usually just tell them too, over time, their auditory system will kind of develop filters and they'll be able to tune out those sounds.
Yep.
At first, they're going to hear them and they're going to be very present.
Right, because what's happened is those sounds have gotten softer and softer as your loss progressed. So your brain didn't have to choose, should I pay attention, shouldn't I pay attention? It didn't have to make that choice. So you just sat there and said, well, I don't hear anything, so that's fine. And if people shouted at you, you could hear them. Now, is there a specific time of the day or a certain occurrence that people would notice their tinnitus more?
At night,
And why is that?
Yeah, because it's quieter and there's not a lot of background noise unless they have a fan running or something that would create that.
Okay. Now, in the last session, I was talking about tinnitus measurements, where you would do a matching to see. I'm presenting. I have on my audiometer. Let's say if you don't have a continuously variable audiometer, you have octave and half octave frequencies that you can present. And what you're doing is you're trying to get the person to just get you into the range. You'll put something in, is your ringing higher or lower than this? Of course, you have to be careful, because sometimes when you say higher or lower, they think it's intensity, but it's not. You have to explain, well, is it a higher pitch? Is it a lower pitch? Is it louder or softer? Comes into it. But when you're doing that frequency measurement, that's what we're trying to match. So if we're trying to put a counter signal in, we have to figure out what pitch the frequency is. Who did the initial studies on that? you remember? One way I've found to easily remember it is I think I told the story about when I was in grad school, we used to say, all right, you take your pet chicken, Charlie, to a rock concert. The rock concert is loud enough that both you and Charlie get hearing loss from the exposure. A week later, Charlie's hearing is back to normal, but yours isn't. Because chicken, for some reason, have the ability to regrow the hair cells in their inner ear. This is what started the basic research and concepts of why can't we regrow the hair cells in a human's ear? And that study was started, again, back in the 70s. They are now using stem cells and carrier viruses to get the cells into the inner ear, and they're trying to develop something to actually regrow the hair cells, which would probably close down our entire industry rather quickly. But then everybody would be hearing better. The way that I've remembered who started the initial frequency measurements, the frequency and intensity of tinnitus, was that his name was Fowler. So I remember chicken, Fowler, because it's a fowl. I know it's a stretch, but it worked for me. But he was one of the first researchers to actually try and say, okay, we know that people say that they have noises in their head. Is there a pitch? Okay, people who complain most of the ringing in their ears have what type of hearing loss?
Possible noise induced.
Right. Trauma, long-term exposure, some type of noise-induced loss. If a person is saying that their tinnitus is like crickets, that would go along with noise-induced loss. Chirping would go along with that. I've had people say that there was a roaring or a rushing, loud rushing sound. What could possibly that be a symptom of? A roaring type of tinnitus.
Meniere's.
You got
Yeah,
it.
Meniere's disease.
Okay.
My life.
Okay. Last time I was talking about sensation level versus hearing level. What is the definition of sensation level? I apologize for slurping my tea so much. We just finished 2 hours of Mark Twain and being a gold miner rehearsals. And I've been talking like this for the last 2 hours. So my throat's kind of dry. Golly, that's the biggest frog I ever did see. Anyway.
How often are you in theater?
Sometimes it feels too often. We just closed Adam's Family, and I had accepted. I said that I would help them out, and this is a children's production. It's a one act. So it's the Celebrated Jumping Frog of Calaveras County by Mark Twain. And we've had 2 weeks of rehearsal, and we go up on this weekend. So it's going to be fast. Almost
My
painless.
daughter,
She does?
Yeah, she's a stage manager.
Oh, she's like my daughter. She gets to boss everybody around. My daughter does that even when she's not the stage manager.
Right. I know the feeling.
Okay. What is the difference between sensation level and hearing level? Take a guess. You're not sure. What would you think the difference in the terms would be?
Well, it's the intensity level. I know that for sensation.
Okay, but let's say we're giving you a measurement. We're saying, okay, this is 10 dB SL, so it's 10 dB sensation level. If I were to say this is 10 dB HL, hearing level, what would that be? Is there a difference between the two? Are they the same?
No, they're not the same because
Gotta subtract 20
Right.
from whatever the presentation level I think is that, or yeah, something like that.
Okay, well, usually when they're looking at speech reception thresholds versus pure tone averages, they take into consideration that there is about a 20 dB difference. So having an SRT of 0 and a pure tone average of 0 has the correction already built into it. So everything that's done on the audiometer is HL. Everything on the audiometer has correction factors built in off of SPL, which is sound pressure level, which is the base measurement. SL, which is sensation level, is loudness above your threshold, the individual's threshold. So if your threshold was 40, a 10 dB SL for you would be what? 50, because it's 10 decibel above your threshold. If I present a sound to you at 20 dB SL, I'm presenting it 20 decibel above your threshold. So what the SL stands for is whatever your threshold is, I'm going to be that many decibel above your threshold, which might be different than someone else's threshold. So that's a subjective interpretation because it's going to be different from patient to patient. It's an objective subjective measurement because the subjective is the patient's threshold and the objective is going 10 dB above it. So let's say you have a speech reception threshold of 0 and you present the discrimination, the word recognition test at 35 dB SL. Well, if the threshold is 0, you're presenting it at 35. If the threshold is 35, you're going to present it at 70. But what you're doing is you're giving them a 35 dB signal to noise ratio, or a 35 dB signal to present. Most tinnitus comes in around 9 decibel above your threshold. This is why it's so noticeable to the people. Because as their loss goes down, so they have a 20 dB loss, they'll notice tinnitus, and it'll usually come in. They'll hear it at as if it's 29, because it's 9 decibel louder than their threshold. So there's about a 9 to 10 decibel sensation level. Have they found any medications that are successful for treating tinnitus?
No, their only hope is that possible amplification or using maskers will help.
Right. Because most of these home remedies and homeopathic medications that they give you, or the B12 drops you put in your ear, they don't really do it. Most of those would be placebo effect more so than anything else. They really have not been able to do blind studies and get any kind of validation on those. So what you're saying is masking of some kind. A hearing aid is going to mask it by covering up the sound, correct?
Yes.
A tinnitus masker presents another signal. Again, masking. If we look at the Jastroboffs, and I know we covered some of that material when we were reviewing, they have the TRT, the Tinnitus Retraining Therapy program that they developed. Now, neither of the doctors, husband and wife, they're both doctors. They're physiologists. They are not physicians. They are not audiologists. They started studying this as a phenomena of a temporal lobe loop. And what they do is they counsel the patient the same way that you would counsel the patient. And they try to have the patient accept that that's there, but learn to ignore it. Now, the hard part of that is, all right, if I said to all of you, don't think about a pink elephant, what are you thinking about right now? Pink elephant, right? And don't tell me Paisley. I don't want to hear Paisley. But this is what happens. You get a lot of people that will sit there and the ringing may fade away and they go, wait, is it still there? And as soon as they think about it, they reinforce the noise. It's like getting that jingle stuck in your head from a commercial. As soon as you think about it, you have to get it away from it completely for you not to hear it. And this is what they're doing. They're doing basically counseling and psychological counseling to have you ignore it, which sometimes people find is very difficult. But that's part of it. So, those are some of the main things, masking the tinnitus, counseling the person about the tinnitus, using psychological approaches, again, which is part of counseling. Okay, now, when I was mentioning the Jastroboffs, what did I say that their program was called?
It's TRT, isn't it?
Correct. TRT, Tinnitus Retraining Therapy. And they're trying to desensitize you to the noise. Now I'm trying to think whether it was Fowler or Bain. Oh, it'll come to me later, which is always great when I'm trying to cover the material for you. One of the things, I don't think it's in TRT, but it is another way of approaching tinnitus, because one of the first things I used to ask tinnitus patients is, do you notice it more when certain things seem to be happening, either with food or stress situations or work, or you have a test coming up? Is your ringing getting worse because of that? So one of the things that they can do is they can meditate. So doing a mental stress reduction type of thing. It's like one of those where you see Buddha sitting there and he's meditating, And what you're doing is you're going inside and you're trying to basically focus yourself, and you get these people doing it, that some of them will do it with yoga. And what they're doing is they're trying to lower their stress level. And by doing that, it will lower blood pressure. And by doing that, it may reduce the ringing. So this is another approach. And this also can come through because stress reduction is a mental exercise, and that comes with psychology and counseling as well. So there's a lot of repetition in this. If a person has ringing and you fit them with hearing aids, would the hearing aid aggravate or alleviate tinnitus?
Hopefully alleviate it, but that's not always the case.
Okay, let's say you fit a patient with the hearing aid, put the hearing aid in, and they go, the ringing's louder. What could that be an indication of?
Maybe a medical referral or trying to use a masker as the next step. Or
Possibly.
adjusting the different frequencies to see if maybe the highs are too high.
Possibly. Or, remember what we're doing with when we put a hearing aid in the ear? We're bringing the environmental sounds up to submerge the ringing. Remember the picture, rocks sticking up out of the water. Tide's coming in. You still see the rocks. What would be the best way to get the rocks to disappear? To wait until the tide's all the way in, to bring the water up higher. So if a person, you fit them with the hearing aid and they go, I still hear the ringing. If it's a new fitting and you've underfit because most patients need to adjust to the sound gradually, it's very possible that you're under amplifying. If you know that they're not going to be able to accept the sound, you might try in the office bringing the amplification up and see if you can cover up the ringing, but maybe not send them home with that and just say, okay, what we're going to be doing is two things. I'm going to give you a gradual increase over time as you adjust to hearing. And what that will do is over time, it will cover up the ringing. And it may not completely cover it up. Now, I know that most of you probably have never seen cases where you can actually put a stethoscope up to the person's ear and hear the noise in their ear. That sounds really weird. That is a physiological ringing, which can occur from middle ear muscle spasm, from the tensor tympani or the stapedius muscle. There's a couple of things that can do that. Very rare, but it has been documented. What would allow tinnitus, when we were talking about Fowler and doing the matching on intensity, what would a loudest type of ringing be, of noise in the head? A truck engine, something like that, or louder? Now, that was a bit of a curve I threw there. One patient that was in a study with the American Tinnitus Association, of some of the earlier research that was done. How loud did they have to make a sound before it covered or matched the ringing in this person's ear, the noise in this person's head?
I think it would vary by what the patient has, whether it's noise induced or something like Meniere's.
Okay. This particular patient in this study did a loudness match of the noises in his head, and the equivalent sound that matched it was a jet on takeoff inside his head. And he couldn't shut it off. And he couldn't get away from it. He couldn't work. And it was a very sad case. And if I remember correctly, he committed suicide after a while. But
Sad.
that's how loud it was. You know, and you can't do this and get away from it, because what are you doing? You're blocking out the environment, right? So I mean, that was a horrible case. But that was about the loudest that they've been able to document. But these are some of the things that, you know, you will see with patients. Very rarely will you get somebody with a case that loud. But
So mine's usually 4K is where it kind of blends in, probably around 50, somewhere, probably 40 or 50 dB.
mm-hmm.
So it's a pretty average sound that it'll blend in. So I have to have warble every time. I can't distinguish the difference in a tone.
Mm-hmm. And that's because when you get, you know, when you get to that point, the sound you're listening to and the sound that's coming in, you know, which came first, the chicken or the egg?
Right.
Yeah. And the frustration with that is you're carrying it around constantly.
You get used to it, but it's very annoying at times because it seems like it's more amplified at times than others. You have to learn to adapt to it, and it took me a very, very long time to be comfortable with it. So
yeah, I think the only time that there's an advantage to that is, you know, during political speeches, because then you don't have to be careful. Depends on what part of the country you're talking about. Anyway,
it's like you might run out of time. It's saying less than 1 minute.
yeah, mine says less than 10 minutes is what we're going to. But that's basically what we're going to be doing as far as the upcoming quiz. That's the kind of material we're going to be covering. Just do a general review. The material that was presented in the PowerPoints should more than cover what we've covered.
Okay.
And the material that we just reviewed today should give you a good foundation for this next quiz. So if you have any specific questions,